Hi everyone, my name is Olivia Cole, and today I'll be sharing my evidence-based practice project, which explores how combining mindful-based cognitive therapy, also known as MBCT, with the maintenance antidepressant medication and how those can help prevent relapse in adults with major depressive disorder. This topic is really important to me as a future psychiatric and mental health nurse practitioner because depression is one of the most common and challenging conditions that we treat, and preventing relapse can truly change a person's quality of life. Some background and significance of major depressive disorder is that it affects 21 million adults in the US, according to the National Institute of Mental Health. Even with treatment, many people relapse, almost 50% within 2 years of recovery, especially when treatment is limited to medication alone. This shows us that medications, while helpful, aren't always enough. As a nurse working in mental health, I've seen how many and how often we rely on prescriptions without exploring the root cause or offering additional supports. This is where mindfulness-based cognitive therapy comes in. It's a structured therapy that teaches people how to recognize their negative thought patterns, reduce rumination, and respond to stress more skillfully. When used alongside of medication, it offers a more holistic approach to healing. And I would beg a more empowered approach to healing as well. The theoretical framework that guides my project is the biosocial model developed by George Engel. It reminds us that health isn't just physical, it's also psychological and social. And depression isn't just a chemical imbalance, it's also influenced by things like stress, trauma, isolation, and life changes. Mindfulness-based cognitive therapy fits into this model beautifully because it helps people build awareness of their thoughts and emotions, create healthier routines and support systems, and influence how the brain responds to stress. As NPs moving forward, this reminds us to treat the whole person and not just their symptoms. Some of the proposed interventions and supporting evidence for my research was the integration of mindfulness-based cognitive therapy in addition to antidepressant medication for adults who are currently in remission from depression. Mindfulness-based cognitive therapy is typically delivered in 8 weekly sessions, either in person or online, and it focuses on mindfulness, cognitive behavioral techniques, and daily practice. The research strongly supports this approach. Gao in 2022 showed that mindfulness-based cognitive therapy plus medication significantly reduced relapse rates compared to just medication alone. And Belvedere at 2021 found that mindfulness-based practice improved both mood and long-term stability in clients with recurrent depression. Williams, 2022, also emphasized that mindfulness-based cognitive therapy helped individuals maintain emotional regulation and awareness even after their treatment ended. Huge. The combination strategy is safe, effective, cost-effective, and evidence-based, and can be led by all advanced nurse practices moving forward. My implementation plan in the real clinical setting would be to identify my patients. So that's adults diagnosed with major depressive disorder, currently in remission, and already taking their maintenance antidepressants. I would screen with tools like the PHQ-9, looking for their baseline, and any type of relapse history questionnaire that I can come up with. The intervention would then be to offer an 8-week mindfulness-based cognitive therapy group led by a trained facilitator alongside continued medication use, of course. Patients would attend weekly sessions, receive their home practice materials, and check in weekly with the provider, me. The evaluation would then be to measure relapse rates, their medication adherence, and again their PHQ-9s over the 6 months, to assess their effectiveness. The timeline here is 6 months. During month 1, I would recruit patients and prepare the facilitators. Group 2 through 3, month 2 through 3, begin the mindfulness-based cognitive therapy sessions, monitoring mood and medication adherence, and then months 4 through 6, doing follow-ups, assessing outcomes, using PHQ-9 again, and adjusting care plans as needed. The outcome measurements for this is, of course, the goal is to reduce relapse rates and improve long-term outcomes. So by that, we would track the PHQ-9 scores at baseline, 8 weeks, and 6 months at the minimum, and rates of relapse within 6 months as well. Patient supported outcomes, their quality of life, their emotional regulation, their stress levels would also be measured, and medication adherence as well to promote and continued engagement with their care. Dissemination, of course, is extremely important, and this kind of research is why we want to disseminate and create real-world change. We need to share work that shows that we are raising the standard of care. I would present this project at a professional nursing conference or local behavioral health symposium, and I would also want to share it within my organization through staff education and quality improvement meetings. Even just posting about mindfulness-based cognitive therapy on professional platforms or social media could help others learn about the evidence and bring it into their own practice. As Melnick in 2023 reminds us, the dissemination is the final step of evidence-based practice, and that's what makes the work meaningful. In closing, depression relapse rates are a major challenge. It's one that we can improve on with evidence-based holistic strategies like mindfulness-based cognitive therapy. And as a future psychiatric and mental health nurse practitioner, I believe it's our job to not just care for the symptoms, but for care for the people. Mindfulness-based cognitive therapy is an accessible, proven tool that empowers patients to stay well, not just for now, but for the long haul. Thank you so much for listening, and I would love to hear and answer any of your thoughts.